All right then. My name is Joseph Pyatt. I'm a neurosurgeon at the Alfred I. DuPont Hospital for Children in Wilmington. And I'm here with Dr. Bonnie Carr, a neuro-oncologist. Our theme this morning is precision management, precision medicine in the management of pediatric brain tumors. To be precise, know your targets. Brain tumor biopsy for molecular diagnosis. Next slide, please. I'm going to begin with a case history. This child was 10 years old when he came to attention in 2016 with headaches. He had a visibly big head. Brain imaging showed hydrocephalus, chronic hydrocephalus, related to a tumor of the hypothalamus and chiasm extending into the basal ganglia and the temporal stem on the right side. His hydrocephalus was treated with a CSF shunt, and his tumor was biopsied endoscopically through the right lateral ventricle, where tumor was presenting on the floor of the ventricle. The diagnosis was pilocytic astrocytoma. He was treated for a year with carboplatin and vincristine with the object of avoiding or withholding radiation therapy. Then he was observed until 2019 when his tumor progressed. At the time of his original diagnosis, there was no molecular testing available, so repeat biopsy was requested for molecular diagnosis. The options were a stereotactic needle biopsy or an open biopsy. As it happened, an open approach was simple, as bulk tumor was presenting in the right temporal horn. The molecular diagnosis was a poorly characterized BRAF mutation that you can see on the slide. The tumor was isocitrate dehydrogenase wild and ATRX wild. Because the mutation was poorly characterized and its responsiveness to targeted therapy was unknown, additional treatment with vinblastine was elected with dabrafenib, a BRAF inhibitor, and trametinib, a MEK inhibitor, held in reserve for use at some later time. Next slide. So this was his presenting brain imaging. You can see he has hydrocephalus and a tumor in the hypothalamus and the chiasm extending into the temporal horn on the right side there. Next slide. This was brain imaging at the time of his progression in 2019. The bulk tumor in the medial wall of the right temporal horn was biopsied through this sulcus on an ultrasound guided approach using a tubular retractor. And as noted, the molecular diagnosis was a poorly characterized BRAF mutation. So the point of this presentation is that this child was subjected to repeat diagnosis for the purpose of molecular diagnosis of his progressive, benign, unresectable tumor. I'm going to turn the talk now to Dr. Carr, my colleague, and she will carry on from here.
Thank you so much for the kind introduction, Dr. Pyatt. And as you mentioned, certainly the molecular diagnosis has revolutionized how we diagnose brain tumors, prognosticate, and treat in 2020. So just to give you a brief introduction, why do we care about the molecular diagnosis? What has changed in past 4 to 5 years? So in 2016, for the first time, WHO classification for the CNS tumor included molecular parameters in addition to histology to define how we diagnose tumors. Another thing to remember is the pediatric gliomas are distinct from adult gliomas because pediatric gliomas are genetically homogeneous and harbor few genetic drivers. And there's a potential for the targeted therapies more in pediatric gliomas in comparison to the adult gliomas. And again, just to give you an idea what exactly the molecular diagnosis changes in terms of diagnosis, we're using a technique called precision medicine, and this is different than traditional medicine and stratified medicine. 20 years ago, with traditional medicine, for example, with IV chemotherapy, there was just one treatment that was given to a group of patients. Some had benefit, others did not have benefit, and several patients had adverse events from a treatment. And then with stratified medicine, we evolved the treatment further based on the disease subtype, patient's risk profile, their demographics, their socioeconomic factors, biomarkers. And with stratified medicine, patient groups with these profiles benefited, but not all the patients benefited from stratified medicine. And in molecular era, with precision medicine, we are using genomics to define tumors. We also look at other factors such as lifestyle, patients' preferences, their health history, their medical records, compliance. When we take all those factors into account, each and every patient benefits from precision medicine. Just to share our experience at Alfred I. DuPont Hospital for Children, next two tables will talk about 10 patients that underwent biopsy for the molecular diagnosis. We'll discuss how it changed their diagnoses, treatment that we chose for these patients, and of course the outcome for these patients. So the first patient on the list is a young lady who was diagnosed with a tumor in her medulla, and on the biopsy, the pathology diagnosis was ganglioglioma, WHO grade 1. She was found to have a point mutation in BRAF V600E. She was switched from traditional chemotherapy to tumor-targeted therapy, which we will talk about in a few. And we use these two drugs, which Dr. Pyatt also mentioned, dabrafenib, it's a BRAF inhibitor, and a trametinib, MEK inhibitor. After we started the combination of these two drugs, we got about 25% reduction in the tumor volume within 6 weeks of starting the treatment. If you look at these two tables, most of the patients that we are talking about, their location diagnosis or by histology, these are low-grade gliomas and mainly hypothalamic optic pathway gliomas. 6 years ago, not many of optic pathway gliomas were biopsied because we thought all these optic pathway gliomas were pilocytic astrocytoma, and the treatment would not change based on the histological or molecular diagnosis. But with evolution in molecular era, we do know that not all low-grade gliomas are similar at the genetic level. So patient number 2 had a hypothalamic optic pathway glioma that had progressed through at least 5 lines of chemotherapy. He underwent a biopsy and was found to have BRAF V600E mutation, which we targeted with the combination of 2 drugs, dabrafenib and trametinib. The patient had an excellent response within few weeks of starting the drug, and he is more than a year out on the treatment with a stable disease. Patient number 3 had a similar tumor location, however, a different histological and the molecular diagnosis. As I said, not all hypothalamic optic pathway gliomas are pilocytic astrocytomas. And also the mutational profile could be completely different. Similar to our second patient, this young boy, his tumor had progressed through several lines of chemotherapy. And when we reanalyzed his tumor biopsy results for the molecular profile, he was found to have NAC2 NTRK fusion, which we targeted with a drug called larotrectinib, which is a tyrosine kinase inhibitor. And we saw a partial response, greater than 50% tumor reduction within 12 weeks. And now the tumor is stable for more than a year out without any significant toxicity. And number 4, again, if I think I'm re-emphasizing the point that you see patient number 2, 3, and 4 had similar tumor location 5 years ago. They will be all treated with the same IV chemotherapy. However, in 2020, all these 3 patients will be treated with different drugs and with individualized therapy. And the 4th patient on the list had juvenile pilocytic astrocytoma by histological diagnosis, and the tumor harbored a fusion called BRAF KIAA fusion, which we targeted with trametinib. Again, we saw an excellent response for this patient. She had stable disease for almost a year. Unfortunately, we had to discontinue trametinib because her liver enzymes were elevated in setting of her underlying liver condition known as non-alcoholic fatty liver disease. Not all the outcomes are always good, and I really want to reiterate that point, that the whole idea of molecular diagnosis is not just to treat and have good outcomes, but in some aggressive tumors, it also helps us to prognosticate. And patient number 5 is a perfect example of that. This young lady had a brain tumor located in medulla and upper cervical cord, which was, of course, difficult to resect, or rather, should I say, it's unresectable tumor. And based on pathology results, she was diagnosed with diffuse midline glioma. And on the molecular diagnosis, my apologies, it should be H3K27M mutation, which is a histone mutation. She was eligible for a drug called ONC201, which is a dopamine agonist. However, the family opted for palliative Avastin or bevacizumab. She has aggressive disease. She's doing well at this point. Of course, she has poor prognosis given the diagnosis. And once we find this histone mutation, H3K27M, we are able to prognosticate these patients. And we can certainly talk more about the survival, what medications are out there. Unfortunately, we don't have good treatment options for a diagnosis like this. And then moving on to second table, which has 5 more patients. And as I said, again, the take-home point is going to be that not all hypothalamic optic pathway gliomas are treated the same way. Not all hypothalamic optic pathway gliomas are pilocytic astrocytomas, and not all the hypothalamic optic pathway gliomas carry the same genetic alteration. Number 6, our patient, a young boy with hypothalamic optic pathway glioma, was diagnosed with pielomyxoid astrocytoma, which is not a new entity as per new WHO grading, but in the new WHO classification, we're still sort of divided as to if it should be a WHO grade 1 versus WHO grade 2 tumor. The molecular diagnosis for this patient revealed alteration in FGFR1 and PTPN11, which we targeted with trametinib, which is a MEK inhibitor. Unfortunately, this patient had intracranial hemorrhage, which is not due to trametinib, but because of hotspot mutation in FGFR1. Number 7 patient is the patient that Dr. Pyatt discussed during his case study. And again, this young man had a diagnosis of hypothalamic optic pathway glioma. And we wanted to avoid radiation and offer some novel treatment options, which will limit the chances for toxicity for this young man. We found a complex BRAF mutation on his molecular profile, which can be targeted. However, we don't know if the efficacy of the tumor-targeted therapy would be good enough to give us a good tumor response. So we opted for vinblastine. He's doing great and has a stable disease since starting vinblastine. Similar to the patient that I discussed earlier, then there are patients where the tumor is located, for example, in brainstem. And again, these are unresectable tumors. However, we are able to biopsy these tumors to confirm the histological diagnosis and also to see if we can find a targetable alteration or a mutation that can help us with prognostication. And patient number 8 has a rare tumor known as ETMR, embryonal tumor with multi-layered rosette, C90 MYC altered. And on the molecular profile, this tumor had multiple copy number changes. Unfortunately, again, for this tumor, there is no tumor-targeted therapy. We opted for radiation followed by palliative chemotherapy. And these tumors have a poor median survival, at times up to 12 months from diagnosis. The patient died of her diagnosis. She succumbed to this aggressive brain tumor. However, the family opted for autopsy to procure the tumor specimen, which we plan to use for the xenograft models, so that in the future, hopefully when one day there are treatment options, we can use this data to develop new drugs that will help similar patients. And again, our favorite tumor on this list, patient number 9, has a hypothalamic optic pathway glioma, pilocytic astrocytoma by histology, and this patient's tumor harbors a fusion, BRAF-KIA fusion, which, as we discussed earlier, can be targeted with trametinib. But given the fact this patient had sudden decline in vision, based on the data that we have for bevacizumab, we decided to treat this optic pathway glioma with bevacizumab with a plan to switch to a MEK inhibitor after this patient finishes treatment with bevacizumab. And the last patient on this list is really interesting, and the take-home point for the last patient is that the tumor was so tiny and the biopsy specimen was so small, and we were still not sure about the diagnosis based on histology. And this is where the molecular diagnosis helped us to define this newly found rare pediatric tumor known as myxoid glioneuronal tumor. This young lady had a small tumor right next to the right lateral ventricle, which was diagnosed as pilocytic astrocytoma by histology. But in the molecular diagnosis, we found a dinucleotide mutation in PDGFRA oncogene. We're planning to offer family an option for SRS for the residual tumor, as in the literature, other patients with a similar diagnosis, there's increased risk for leptomeningeal spread. We've been talking so much about targeted therapy, all these drugs and new drugs, but what exactly is targeted therapy? So as per a National Cancer Institute, it can be any treatment that uses drugs or substances to identify and attack specific type of cancer cells with less harm to the normal cells. Some targeted therapies can block action of certain enzymes, proteins, other molecules involved in growth and spread of cancer cells. And then there are other type of targeted therapies that we did not talk about today that can help the immune system kill cancer cells or deliver toxic substances directly to the cancer cells and kill them. The goal here of precision medicine is the individualized treatment, while we try to limit the side effects compared to traditional cancer treatments. Most of these targeted therapies are small molecule drugs or monoclonal antibodies. Earlier focus has been on adult brain tumors or adult systemic tumors like lung cancer, melanoma, breast and ovarian cancer. There has been increased focus on pediatric brain tumors for past 5 years or so because of the updated WHO classification in 2016 that included the molecular profile of these tumors. So far, you've heard these terminology a lot from Dr. Pyatt and I. The take-home message is going to be, at least we should be able to understand the difference between BRAF point mutation and BRAF fusion. And as I said, these alterations are fairly common in pediatric low-grade gliomas, especially genomic alteration in BRAF and ERK MAP kinase pathway is very common in sporadic cases of pilocytic astrocytoma. BRAF fusion can produce a BRAF fusion protein, which can activate the MAP kinase pathway. But besides BRAF, there are other genetic alterations that one could see in pediatric gliomas. And I hope you notice that through that table, the 10 patients had very different genetic alterations. Other common genetic alterations are RAF1 rearrangement, RAS mutation. And another thing I really want to focus on is that there is a difference between point mutation and BRAF fusion. If a tumor harbors a BRAF fusion, it predicts better clinical outcome. There are increased chances of progression-free survival and overall survival. There are other factors as well in the molecular profile that actually impact the outcome. And these include cyclin kinase 2A deletion, whole chromosome 7 gain, and tumor location. Doesn't matter if a tumor has favorable genetic profile, but if it's located in brainstem, the outcome will be poor just because we're not able to resect such tumors. So tumor location certainly plays a big role in terms of predicting outcome. And again, to go back to BRAF mutation and fusion, one must remember that BRAF mutations can be seen not only in pilocytic astrocytoma, but also in other low-grade tumors such as ganglioglioma, desmoplastic infantile ganglioglioma. More than 2/3 of patients with pleomorphic xanthoastrocytoma. As opposed to BRAF fusion, BRAF point mutation confers a poor progression-free survival. In a large series where they looked at about 400 children with low-grade gliomas, only 17% tumors had a BRAF V600E point mutation. And a 10-year progression survival was 27% compared to 60% for those who did not harbor the point mutation. So mutation is bad, fusion is good, but both mutation and fusion can be targeted with tumor-targeted therapy. And other mutations, which again, you must have noticed in that table where we talked about our patients, includes activating mutations in FGFR1, PTPN11, and NTRK2 fusion. And these mutations have been identified in non-cerebellar pilocytic astrocytomas and also in other low-grade gliomas. You've heard a few names about the tumor-targeted options, but this list will give you the drugs that we've been using commonly in 2020 to target some of these tumors with targetable alterations. And the first one on the list is DEBU1347. It's a pan-FGFR inhibitor. It's not in pediatric clinical trials as yet. There will be a phase 1 clinical trial opening pretty soon for pediatric brain tumors that harbor FGFR mutations. Number 2 is larotrectinib, which targets the NTRK gene fusion. It's the first drug to gain FDA approval for both pediatric and adult solid tumors. And this drug is a game changer, well tolerated without significant toxicity. And the number 3 is dabrafenib and trametinib. Dabrafenib is a BRAF inhibitor. Trametinib is a MEK inhibitor. These two drugs are used as a monotherapy or as a combination based on the genomic profile of the tumor. Binimetinib is another small molecule MEK inhibitor. It's a next generation MEK inhibitor, thought to be slightly better than trametinib, but of course, there's no head-to-head comparison for us to tell if binimetinib is actually better than trametinib. But I thought that in theory, since it's a smaller molecule, we think that it crosses blood-brain barrier better than trametinib would. And ONC201 is, as I mentioned earlier, it's a dopamine agonist. It's in pediatric clinical trial. There are 5 arms for diffusely infiltrating midline gliomas or with the diagnosis of DIPG. Last but not the least on this list is selumetinib, which is a MEK inhibitor and got FDA approval in April 2020 for inoperable plexiform neurofibromas. Not only this drug is effective against plexiform neurofibromas, in recent studies from Pediatric Brain Tumor Consortium, it did show efficacy even in brain tumors. So certainly selumetinib is another game changer on this list. This is the last slide, and I just want to emphasize again how things have evolved and changed in past 4 to 5 years. These are children's oncology group clinical trials that are open right now and accruing patients. And if you look at these 4 clinical trials, these 4 clinical trials are using the molecular data, which we did not use for clinical trials 5 years ago. So there certainly has been more emphasis on using molecular profile of tumors to design clinical trials. ACNS 1723 is using BRAF and MEK inhibitor for high-grade gliomas. ACNS 1831 is using selumetinib, a MEK inhibitor, and comparing it to traditional chemotherapy with carboplatin and vincristine in patients who have NF-related low-grade glioma. And ACNS 1833, again, is comparison between traditional chemotherapy with carboplatin, vincristine versus selumetinib, which is a MEK inhibitor. So the take-home point for our talk today is that molecular profiling of tumor helps us to diagnose these tumors, treat, pick up the right treatment options, and also prognosticate certain patients where we don't have good treatment options as yet. And hopefully it will also help us develop new drugs and new treatment options in the near future. Thank you so much. And we will be happy to take any questions that you may have for Dr. Payat or for me. Thank you.
De acuerdo. Bueno, muchas gracias. La verdad es que fue interesantísima el aporte de los doctores Kaur y los doctores Payat en cuanto a los perfiles moleculares de estos tumores que son de difícil manejo en todas partes del mundo. De acuerdo. Entonces, estamos adelantados con respecto al programa, así que tomaremos el tiempo para si algunos de los participantes quieren hacer sus preguntas ahora a los doctores Kaur y al doctor Payat, estaremos abriendo esa oportunidad. De acuerdo. Una pregunta que a mí me gustaría hacer a los doctores es, ¿este perfil molecular ahora mismo se está implementando para todos los pacientes que se diagnostican con un tumor cerebral en niños, o simplemente para aquellos que se consideran, como dijeron, inoperables o de difícil manejo desde el punto de vista quirúrgico? ¿Cuál es el protocolo, digamos, cuando se presenta un paciente con un tumor recién diagnosticado en su institución?
I think we'll need some help with the translation, if you don't mind.
Yeah, Doctor, will you mind to repeat the question so I can do a translation?
Sí, claro, no hay ningún problema. La pregunta va dirigida en cuanto al perfil molecular, si se está implementando para cada paciente que se diagnostica con un tumor cerebral, ya sea cualquiera la localización, o bien si solamente en aquellos que se consideran irresecables, como los que presentaron, los tumores de tallo cerebral o los tumores de vía óptica o hipotalámicos. O sea, ¿cuál es el protocolo y cómo vamos dirigido el workup de esos pacientes antes de ofrecerle tratamiento?
So that's going to be, just bear with me because that was a long one. so how is the process to do the, how is the protocol to do the assessment, the molecular assessment and the type of cancer that the patient has in order for you to start the process? Is there a protocol that you follow up step by step, or is there something that you do different whenever you have a patient with a cancer in different parts of the brain?
Dr. Pyatt, would you like me to answer that question, or?
Well, we consider a second look biopsy for molecular diagnosis for any patient who has a tumor that cannot be resected and who has failed conventional therapy, and for whom we want to avoid radiation therapy. That's the class of patients for whom we consider second look biopsy. Do you want to add anything, Dr. Kaur?
And to answer, thank you so much, Dr. Pyatt. And to answer your question about following a protocol in terms of how do we decide if a patient's tumor should be sent for molecular profiling based on location of the tumor. So that's a really good question. We are trying to send molecular profile on 100% of our brain tumors because we do know that, as I mentioned earlier, we may or may not find a targetable alteration or a mutation that can be targeted with a drug. The molecular profile does help us define these tumors for a better integrated diagnosis, and also many times helps us to prognosticate these tumors. We can have a discussion with family based on the genetic profile of a tumor, if a patient will do better with a certain type of treatments, and also about the long-term survival. And many times it also helps us, as I said, with the integrated diagnosis where there's a discrepancy between a pathology diagnosis versus a molecular diagnosis. Did we answer your question?
Sí, en realidad no, lo entiendo perfectamente. Entonces, otra pregunta que surge es, ¿han podido identificar ciertos perfiles moleculares más frecuentes que otros? O sea, ¿hay una preponderancia por aquellos que se presentan con mayor frecuencia y en dado caso de los que se presentan con más frecuencia, si ya se está haciendo estándar el tratamiento con ciertas drogas o simplemente se está llevando paciente por paciente?
Have you been able to identify certain molecular profiles that are more frequent in this type of patients? And if so, is there a specific treatment that you develop for those type of patients based on the molecular profile that they share?
Absolutely, that's a really good question. We do know that low-grade gliomas, as we talked about, and several of our patients we talked about today with hypothalamic optic pathway gliomas have a fusion called BRAF fusion, and the aggressive tumors within low-grade glioma subgroup carry a mutation, a point mutation called BRAF V600E. So there are specific agents or drugs that we use for these mutations and fusion. our preference always is to enroll a patient on a clinical trial. And as we discussed earlier, the Children's Oncology Group clinical trials are also based on the molecular profile of these tumors. So absolutely in 2020, we do know of the mutation that we can target with certain drugs.
Gracias. Una última pregunta dirigida entonces al doctor Piat, es como neurocirujano pediátrico, si esta implementación del perfil molecular, ¿cómo ha impactado su filosofía en cuanto al manejo de estos pacientes desde el punto de vista quirúrgico? Tendemos a ser más agresivos con la resección tumoral, tendemos a ser menos agresivos. ¿Cómo este conocimiento reciente en la medicina le ha ayudado a evolucionar el manejo de el manejo quirúrgico de estos pacientes?
Dr. Payat, with this advancement in technology and in diagnosis and treatment, how this has affected your practice while being you a neurosurgeon while treating these patients? Are you more aggressive on the resection of tumors? Are you less aggressive? How this change your practice based on your to the treatment you provide to your patients?
Well, thank you for that question. I am as aggressive as I ever was in attempting to remove tumors that can be removed. So the goal is always to remove a tumor that can be removed. But that's not what we're talking about. We're talking about unresectable tumors in the brainstem, the thalamus, or the hypothalamus and optic chiasm. I have to say that my collaboration with Dr. Kaur has made me more eager to biopsy these things, as I expect you have access to frameless stereotactic technology that is very safe and relatively simple in the modern time. And I have to say, I like to biopsy these chiasmatic tumors through infraciliary frontal orbital mini craniotomies. That's a, that's a fun operation and relatively simple and of low morbidity for the patient. Several of these children were biopsied through an orbitofrontal mini craniotomy. So yes, I have a much lower threshold now for taking a second look at progressive tumors resistant to conventional treatment.
De acuerdo, muchas gracias. Y estoy de acuerdo.
And just to add on, just so the audience know, sorry, I think just to add on, so that the audience know that most of these patients had progressed through at least 3 lines of IV chemotherapy. So we're not using biopsy as a first go-to. Some of these patients are, they were diagnosed more than 10 years out. So there were not additional treatment options available, or we thought, as Dr. Payat mentioned, that radiation was not the right next step, and we wanted to offer the tumor-targeted therapy to these patients.